Good evening, I'm Jim Robertson, and this is League of Women Voters Presents. Our topic tonight is what is the real cost of not expanding Medicaid in Missouri? Our guests are Dr. Stephen Kaitan on my left. He's the Assistant Professor of Clinical Medicine and Pediatrics at MU and Medical Director at Woodrow General Internal Medicine and Pediatrics Clinic. To his left is Thomas McAuliffe, Director of Health Policy at the Missouri Foundation for Health. And over to our far left is Stephen Rennie, Vice President of Children's Health and Medicaid Advocacy for the Missouri Hospital Association. Thanks for joining us tonight, gentlemen. And this topic is large and complex, and I hope that we can have a discussion that will shed some light on it for our viewers. Some facts, I think they're facts. Sometimes it's hard to tell, and feel free to correct these so-called facts that I've gathered about Medicaid expansion. Medicaid is the single most expensive program operated by the state of Missouri. Can we agree on that?
Yes.
No argument. Some 900,000 Missourians are currently covered in an annual cost of nearly $9 billion. Missouri covers, the state treasury covers about $3.4 billion of that cost. In the past 5 years, the cost has gone up nearly $1 billion. That may be subject to some discussion. An expansion of Medicaid in Missouri by federal guidelines would add about 300,000, I've heard anywhere from 280 to 350,000 Missourians to the Medicaid rolls. The federal government would pay 100% of the increased cost for 3 years and 90% of the increased cost after that for a determined period of time. Critics say the cost of the Medicaid program is likely to continue to increase beyond the ability of the federal or state governments to sustain it. Can we afford to expand Medicaid in Missouri? Steve Kaitan?
So it depends on who you ask, and it depends on your values. If you believe that we should try to cover as many people as possible and that these 300,000 people who are the working poor, these people are already working, we already cover children and we cover pregnant women and other subgroups, but this would expand to the working poor from 16% of the poverty level up to 138% now of the poverty level. That's a group that hasn't been covered. So if you believe that they're worth covering, then it's worth the investment. And I think Tom will talk a little bit about the economic benefits of accepting federal dollars for this purpose. But from my world, from what I see, yes, it is a good investment and that's the way I see it, is we are investing in the health of our working force of 300,000 people.
Now this, the jump from 60% of poverty level. 16%
16%.
to 130. 16, that's
16.
Okay.
We're one of the lowest in the country as far as covering working adults.
That's okay, interesting. Well, you work with that population.
Sure.
The uninsured also?
Sure.
Yeah. And do they, what about the argument that they can go to the clinic on Worley or the emergency room,
right,
and they
so,
do?
Yeah, I mean, there's several arguments with that. We have a federally qualified health care facility, Family Health Center in Columbia. And Andy Quint is the medical director there, and you can talk to him about this. But you're much better off having Medicaid than being uninsured there. If you're uninsured, you pay on a scale of what you can pay. But you have so many more benefits if you have Medicaid. The big things that Medicaid doesn't cover is physical therapy, and it has a restricted formula, but that's one thing that keeps the cost down compared to commercial insurance plans. So if you talk to Andy, his patients that have Medicaid actually get pretty good care between the care that he can provide there and the care that the university can provide to Medicaid patients as well, and some providers in the community as well. Doesn't cover dental care, eyeglasses, things like that, but that is a problem for a lot of the health plans. But the opportunities, just from a moral standpoint, it's been estimated that 1 out of 1,000 people that are uninsured will die each year. So if you look at that 300,000 people that we have the opportunity to insure with really which is budget positive for us. We can do that at least for the next 3 years, if not longer. Several hundred of those people, and you don't know who they're going to be, but several hundred those people will die every year. And just a week ago Friday in my office, I had a woman whose son was 28, had influenza. She begged him to go to the ER. He didn't because he didn't have insurance, and he ended up dying.
So those are people whose death was preventable if they'd had the proper medical care.
Correct. That's a case in point. I mean, this is a reality. The other thing is that preventative care works. And so another patient I saw a few months ago, well, I worked as a truck driver 13 out of 14 days. His employer did not provide health insurance. So we had seen him a couple of years ago. He had diabetes, kidney function was a little borderline then. 2 years later, he comes back, and he needs dialysis now. So now, once you're on dialysis, then you go into a different pool, and you get Medicare dollars. And so then our tax dollars are paying for his dialysis. We're going to pay for his kidney transplant because he's a young man. And it's also unfair to him because he's got this miserable life of being on dialysis and kidney transplant. So there's opportunities to help people live better and longer with Medicaid expansion.
Thomas and Steve, why does it make economic sense to expand Medicaid?
Can I answer the question?
You can answer Steve's question.
I might want to ask him first. But.
So, maybe Steve will want to answer.
Steve did a great job. I would just answer the question, can we afford not to expand the Medicaid program? When we think about the jobs, and we can talk about that, but let's talk about the 300,000 plus that are currently uninsured. A majority of them either have full-time positions or live in a household that has a full-time worker in that family, and they have no access to health care other than the emergency room or a clinic, which does not provide the kind of continuum of care that makes them healthier, that brings down their costs in the long run. So when we think about access to better health, one of the first steps in America is to get health insurance. And the access to health insurance is primal. It's primal for their health, it's primal for our economy, it's primal for their children. And we can talk about all of the things that go along. If a parent is uninsured, they're less likely to sign their child up for insurance. If a parent is uninsured, they're less likely to take them to the doctor because there's not the culture of going to a doctor. Let's just gloss all over those complicated facets. Let's get down to the question. What does it take for us to accept $400 million in exchange for $40 million of cost? The federal government will give us, over the next 10 years, over $400 million to expand our Medicaid program to our most vulnerable, to those in most need, at a cost of $40 million. Now, you referenced $1 billion, and that's an interesting figure. I would love to know the variables that went into that. But when we think about how we get the most vulnerable, the most needy insured, that saves our hospitals money, it saves our communities money, it saves our school and other social services money when people have insurance. And the Medicaid program works, it's efficient, there are good outcomes compared to private insurance, and I wouldn't say that they're better when you compare different zip codes, et cetera, but what we're talking about is good care that does not cost a lot to the state relative to what the federal government's willing to kick in. And this is not only an economic argument, it's a moral argument, and it's a preparedness argument. How can we attract businesses to come to our state if we don't have a healthy workforce that shows up to school ready to learn, a healthy workforce that doesn't show up to use that company's insurance to get healthy? I mean, when you start thinking about the economics of it, it's not always easy to put a dollar sign or a figure next to what it takes to be a healthier state. And expanding the Medicaid program is one of the key kind of strategies for getting at people who have been overlooked and are not on the radar of private insurance.
Steve Rennie, from the Hospital Association's viewpoint,
Well, from the hospital's perspective, the expansion of Medicaid is essential to the continued health of Missouri hospitals. The Affordable Care Act was predicated upon expanding coverage while reducing payments to hospitals that help us offset the cost of care to the uninsured. If expansion doesn't happen, the cuts are still in place. And Missouri hospitals can't afford to absorb those cuts. We will be facing reductions of $4 billion between now to the end of the decade, 2019. That's a significant sum of money. Our margins are tight. And absent Medicaid expansion, there's no way that we can absorb that without it having a significant impact on our hospitals' ability to serve their communities. So we believe strongly in it. The Affordable Care Act was paid for in many ways. One way was reduced payments to hospitals. So we think Missouri can afford to do it. The federal funds are attractive, and they do carry the cost for a full 3 years, and reduced payments in the current Medicaid program to hospitals and reduced payments from the Medicare program are offsetting sources.
You mentioned that the payments decrease. In your crystal ball, over 10 years, say we don't expand, Missouri does not expand Medicaid. What are the consequences for Missouri hospitals? How many hospitals are there now? And are we talking about hospital closures?
Yeah, there's 150 hospitals in Missouri, and the ones that we worry most about are rural hospitals, because there's also a conversation that you can have about what's described as the hidden healthcare tax. And when hospitals provide care to the uninsured, that cost gets shifted to commercial coverage, the individual market or businesses. So hospitals that have a good commercial base that can still try to make that shift, they should be okay. But especially when you look at our rural hospitals that depend upon Medicare and Medicaid for the bulk of their business, they don't have the opportunity to do that. So they are at risk, and closures are possible, reduced service lines are possible, and we're seeing some of that now.
I mean, we've heard of emergency rooms possibly closing in rural areas, the exact areas where we see the highest zip code of potential Medicaid expansion enrollees. So that being the irony, where the need is most, those emergency rooms or hospitals may close, and the people who need that will be both out of luck because the legislature has decided not to expand Medicaid, but also out of luck because the hospital that they rely on and the community, one of the major employers of communities, will be going out of business or reducing service lines.
Are there a sufficient number of physicians in Missouri to serve 300,000 more Medicaid patients?
That's a good question. I don't know if you have those numbers. You know, there at the university, there's and the medical schools, there's an initiative to try to attract, recruit, and train medical students who will go out and practice in rural communities. But I heard the argument today that the states that are expanding Medicaid around us may actually recruit and offer incentives to some of our physicians that are here to go out and work in rural communities because they can do so, because they have the opportunity to do that. I don't know if you had an opinion.
There's an enduring debate of whether there's a shortage or a misappropriation. Our primary care physicians moving to areas that there's excess demand, and where there might be need, they're not settling there. The fact is, we know that there are not enough rural physicians who are going to be able to provide the kind of primary care that is not only necessary and needed, but is called for in the Affordable Care Act as a way of improving health and affecting cost savings. So there's going to be a challenge as we move forward for medical schools to incentivize family practitioners. There is something, and as long as we're dealing with a very controversial topic, there is the role of the nurse practitioner. What can nurse practitioners do? Missouri has the most restrictive nurse practitioner regulations in the United States. So perhaps as we move forward, we need to talk about the state government incentivizing people to move to rural areas, as well as revisiting our nurse practitioner.
Or just physician extenders, that includes physician's assistants.
Yes.
And so forth. So it's ways to to sort of take care of patients without using primarily MDs. But that issue, I mean, I think physician supply or provider supply is not a reason to not, you know.
Exactly.
You're right. I mean, that really doesn't play in. I mean, I think
I would argue over time, I think there's enough elasticity in the system that it can be accommodated. You're talking maybe 300,000 people. Missouri's population is 6 million, so it's about 5%. The doctor talked about his truck driver that didn't take treatment since he was uninsured. So I think initially there might be a pent-up demand that could create some stress to the system, but I think the system's elastic enough that over time it can be accommodated.
If we look at Massachusetts, they had this elasticity problem in the first 2 or 3 years. Now, physicians are not leaving. The waiting lines are not like the mythical Canadian wait lines. I mean, the system has worked out. Physicians like it. Most citizens are insured, and the program has near universal acceptance and approval.
What at this point, at the state level, we've been debating this for at least 2 years. What at this point is the biggest hurdle to expanding Medicaid in the state of Missouri? You don't have to name names.
Yeah.
Well, I think there's some strong, you know, political, you know, again, it kind of breaks down to values and political ideology on a lot of this, and and I think trust in the federal government. They'll continue. They'll fulfill their end of the bargain. I think is probably from an economic standpoint. That's the argument that I hear the most, is that the government will renege on their, which they've never done in Medicaid, by the way.
Track record.
For Medicaid, they have a very good track record, and so then it's sort of, you know, is it worth, you know, and then also I hear a lot that Medicaid is severely broken, was what I heard today, and which again, if you talk to those of us who work with Medicaid patients or like Andy Quinn, who works predominantly with the underinsured and the uninsured, it works pretty well for them. I mean, you'd much rather, and you're much better off having Medicaid than not having Medicaid. So its overhead is 2% nationally. The Medicaid overhead is 5.7%. Most commercial plans start at about 12%. And so it's a pretty, again, probably its biggest problem is it doesn't offer the full array that some commercial plans, benefits that some commercial plans have. But again, it's already expensive. So again, it's much, in my opinion, much better than nothing.
And I think that's one thing that we've learned. Medicaid expansion doesn't have to be one size fits all. Other states have customized the expansion. 2 of our neighbor states, Arkansas and Iowa, crafted a solution for their state. They've received approval from the federal government for that. Missouri could do the same. We could reform Medicaid in Missouri and propose expansion that meets our needs and satisfies our concerns. And I think that 26 states have now passed Medicaid expansion. The longer we wait, I think the more we lose our negotiating power and leverage with the federal government on customizing the program. But I think just doing Medicaid expansion or implementing the Affordable Care Act continues to be a highly partisan issue. But the opportunity is there for Missouri to customize it and find the Medicaid reforms that we need to make it work for us and our citizens.
I mean, there's a certain sense, I agree with both of the positions taken here. There's a certain sense, and I don't know if it's reality or not, but there's a sense that this is the year or it won't happen, and that it probably won't happen. So, I mean, the bad news is that next year doesn't seem like it's a possibility, and the bad news is if it doesn't happen this year, it's not going to happen. I think Steve brings up a really good point. The federal government has really moved from being very stringent. It has to be a full expansion, no exceptions. And because so many states did not expand it, the federal government has indicated a willingness to expand with modifications. Arkansas and Iowa are 2 examples, but on the other hand, you have Pennsylvania, which is requiring a work requirement or at least applying for jobs before you can get the Medicaid benefits. And then you have a state like Ohio, which was looking for a far more restrictive, and the federal government has indicated no to Ohio and possibly no to Pennsylvania. So Missouri's the tactic we have to take is staking tacking somewhere between the states that got it, the states that didn't, and looking what works best for our networks, works best for our physician supplies, for our citizens, et cetera. But there is a bit of the window is not closed, but it could close if we do not act with a certain amount of effort and direction.
Now, Representative Jay Barnes spent the summer, last summer, traveling the state with a committee trying to get a sense of Medicaid and reform in Missouri. And apparently he has a plan, a proposal for reform. Are any of you familiar with that?
Yeah, I've looked at the legislation. He's proposing that the state move a long ways towards getting all Medicaid clients in some form of managed care, be it capitated through the insurance companies or accountable care organizations, or Missouri Medicaid today is demonstrating health homes and getting those with chronic conditions in a health home and showing some very promising results in both health outcomes and in cost savings. So the biggest reform that he's talking about is trying to ensure that care management is provided dependent upon the population and dependent upon the diseases that people have.
Now, you don't have to be in a managed care to have a health home,
No,
though.
you do not.
And so, you know, one of the senators who's a physician has had concerns about adding the managed care layer because you're adding a layer of, again, commercial bureaucracy and costs that go along with that commercial management. And whether or not that's really going to give you any benefit and outcomes is a concern that he has, and I personally have. I mean, you already have a low, overhead expense. You know, I'm a big fan of the medical home, which we have we have some pilot models at the university. But whether or not to throw managed care organizations in with it just doesn't seem to make a lot of sense to me either.
There's a couple other components. This is 1901. There's a couple other components. One would allow people to choose a variety of health insurance options, and one of the options being a health savings account. And if they opted for the health savings account, they could keep some of the monies at the end of the year that they didn't use. There is a work requirement. You would have to sign up with a service that would require you apply for a certain number of jobs in a given period, and if you didn't, you could be removed from the rolls. There's a number of components that are related to expanding Medicaid, but getting people to take quote-unquote responsibility for their care, which there are triangulations of many models out there. Many of these things are thought-provoking. They would require an application to the federal government for a modification of our existing program, and some of those components the federal government has indicated yes, and some has indicated no. So as it works its way through the process, it's likely to undergo significant changes. To speak to the representative's acumen, he has spent a great deal of time learning about the Medicaid program. He has delved into the numbers. And to answer the previous question, one of the biggest problems to Medicaid expansion is the fact that lots of times the program is really difficult to really understand, and to get legislators to get that dime store understanding of it very quickly. That doesn't happen. Representative Barnes has spent a long time the summer really digging into it, really 2 years, and he understands the program.
Mm-hmm. Okay, we're going to have to wrap it up here, and I want to wrap it up by asking you each for closing thoughts, but also specifically, if we're making odds, what do we think about Medicaid expansion in Missouri this year?
So starting down here this time. Well, I don't think if it came up for a vote today that it would pass, but the world does move, and so we need to be ready for that. Missouri hospitals are in the Capitol every day supporting Medicaid expansion. We're working with our member hospitals, sharing the impact of them and suggesting they talk to their local legislators and citizens about the significance of Medicaid expansion for Missouri hospitals. So we're hopeful that as session goes, most major legislation doesn't happen until the last few weeks of session, and that is yet to come. So I'm very optimistic and hopeful and a believer in the process. So we think it needs to happen, and I hope it can happen this session.
Thank you.
6 months ago, I was 80-20, it will pass. 2 months ago, I was 20-80, it will not pass. Today, I'm far more hopeful that we will get something. I think there's a certain agreement that we need to transform the current Medicaid program that opens up the door for possible expansion. I'm not sure we can give it odds. I agree with Steve that the process works in mysterious ways, but I think our legislators are aware that the window could close if we don't seize the possibility of getting the federal funds. I might add that one of the ways to get around this is to add a kind of stopgap or a sunset, and if the federal government ever pulls its money back, the state could pull out.
Which they could do anyway.
Yes.
At any time.
Yes.
Yeah, yeah. So, I'm not a gambler, so I won't lay odds, but I do feel that it's one of the most important issues that's facing the health of our state. And that I think a lot of the people in Jeff City legislators are very open-minded to hear a lot of the different options, and we appreciate that. But there's a lot of us that are really pulling strongly for it for the benefit of our patients. Yeah.
Good. Well, thank you very much, gentlemen. You've got an amazing amount of knowledge about Medicaid in Missouri, and I thank you for sharing it with our many viewers. Here's to the health of Missouri.